Hello and welcome to the Infectious Disease Podcast. I'm your host, Zachary Schwartz. In this episode, we answer the question, what's the role of primary care in HBV management? And if you're in primary care, how can you make a difference for people living with HBV? To answer these questions, we'll hear from 3 physicians and a patient advocate, all with first-hand experience. First, we'll hear from Sue Wang, an internist practicing primary care and medical director at the Center for Asian Health and Viral Hepatitis Programs at Cooperman Barnabas Medical Center in New Jersey, and patient advocate Ruth Brogdon, who is the institution's Director of Public Health Programs. They're joined by Dr. Richard Andrews, a family medicine physician who is also president of the Houston Viral Hepatitis Task Force, and from San Francisco, Dr. Amy Tang, who's the former co-chair of the National Task Force on Hepatitis B. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. And to get access to all of our podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. So let's listen in as Sue Wang kicks off the discussion.
Most of us here are probably clinicians, but we all know that in medicine, we operate as a team, right? We rely on our staff to really help provide care. And Ruth is part of my team. She's going to talk about her role here at our practice and with the work that we do. And, I think it's just a reminder that patient support, anybody can be an advocate, from the staff that are answering the phone, setting up appointments for patients, to people who are checking in your patient or triaging them, rooming them, and even in the follow-up work with them. This is a little discussion, she'll cover the topics of, the specialist versus primary care. So let's hear from Ruth.
The primary care serves as a setting to reduce stigma, because if we can bundle hepatitis B, for instance, with hepatitis C or HIV screening, it reduces the stigma of being screened for one particular infectious disease over the other. And we're doing an overall comprehensive screening for the patient. Also, with primary care physicians, it's just a matter of access versus a specialist. I work with our hepatologist who comes to our clinic. We have a lot of patients who call up saying, I have hepatitis B, I need to make an appointment with the hepatologist. And then when you start talking about a specialist, you're talking about wait times to get an appointment. And I'm very easily able to funnel them to our primary care physicians, who are all very well trained in hepatitis care. And then they're able to see the patient right away and start treatment and care.
So I want to kind of ask you guys, what do you do kind of as a primary care physician with Hep B, and when do you refer? Kind of what is your practice like? Amy, I'll start off with you.
Sure. So for me personally, I probably do the bulk of hepatitis B management. I think the exceptions are when I have a patient who has a concerning liver mass, either an elevated AFP with nothing much on imaging, or a normal AFP, or a mass that is a little bit concerning. And so trying to get them into care as soon as possible. And I think the other situation is if the patient has like a Delta co-infection, which we don't see as much in my clinic, or if they have decompensated cirrhosis. I do feel pretty comfortable with managing compensated cirrhosis in our practice. We will have them get an EGD with just like a gastroenterologist periodically, but putting the patient on treatment and monitoring them every 6 months is pretty straightforward. So in general, I am seeing my Hep B patients about every 6 months and ordering those labs just after, viral load and ALT. Sometimes I'm also trending their antigen, antibody status, and of course, their liver cancer surveillance test. And luckily, our system has EHR prompts for all these.
Great. And I think just to also add to the discussion about the different guidelines out there, Dr. Tang was actually the author of primary care-based guidelines, which are actually posted on the University of Washington website. So they're very specific algorithm for primary care physicians. So if people are looking for another resource in addition to the WHO one, there are guidelines out there. And I think one point is that quite a lot of people actually have not complicated disease. So I often will tell people just start ordering the viral load and see, and you'll find a lot of people actually have viral loads under 2,000 or maybe even undetectable. And those are people that are easy to just continue monitoring like once a year when you're seeing, or every 6 months, and to just watch them until things start changing. And then if you're not quite comfortable initiating treatment, then refer then. But at least I think doing some of the initial steps of evaluation is something that primary care providers can do. And even if you're not comfortable with that, maybe it's, HCC screening, at least order that ultrasound for HCC screening or AFP. And there's some things, we can do with that. Rich, I want to see if you wanted to add anything to this discussion about what you do in your practice.
Yeah, well, I totally agree with what you guys said. I would add, I also felt comfortable. And after you've seen a few Hep B patients, you'll see how straightforward this is. When you have a patient with mild to moderate cirrhosis, that is to say compensated cirrhosis or uncomplicated cirrhosis, their management is really not that much different than somebody who has something less than cirrhosis, some degree of fibrosis or perhaps none. But anybody who does have a diagnosis of cirrhosis, that patient, I would typically send them to at least a gastroenterologist in order not to manage the Hep B, which I felt comfortable with, but to make sure they get an EGD or an upper GI scope in order to assess for varices. And then that person should be on some kind of a schedule by that EGD provider so they can keep an eye on that.
Great. Yeah, I think Amy had alluded to that too. I think thinking of it as like a partnership, right? Where you're working alongside a GI or hepatologist, or it could be infectious disease. And I think that team-based approach is really important, especially since, we're often going to see these patients much more often, and they may not need to see the specialist as often, but for some key services, it's important. I'm going to intro Amy's talk actually with another clip from Ruth, because she talks about an example of what a system can do. How do we elevate it beyond just like the physician being the one to make the decision, but what can we do on a system level? And what are some tools out there for increasing even screening? I think if we increase screening, that kind of starts the cascade, right? So screening, then people who need to get vaccinated or people who need care will be identified. So let's move forward with Ruth.
So we have built an automated screening algorithm in our EMR, which basically has automated eligibility, automated the order for the physician. Upon notification that a patient's sample has come back positive, our navigators are notified of that patient's results. And then the navigator is able to call the patient right away, inform them of their results, educate them as to the disease and the next steps. And because the navigator is part of the system, they're able to make an appointment right there for the patient. So the EMR has been really instrumental in taking screening, scaling it up at the hospital level. We've expanded it to multiple hospitals, so we see it as large scale-up screening. There's also the communication tools. Once they come to our clinic, and whether it be the MA or the PSR or the pharmacist or the navigator has some concerns to talk to the provider, it's done all through the EMR. It takes a little bit of time off of the provider in terms of patients asking questions, next steps. What I recommend is just utilize the resources that you have and just redistribute the workload among the resources. In terms of actual, availability of an EMR, I talked a little bit about the EMR that we have and how you can use the EMR to perhaps set up prompts for screening and then follow up and discussion. In terms of, the workload, it doesn't necessarily mean that you need to hire. Take the staff that you have and just develop a plan where staff knows the types of questions that they can answer. Have them work at their highest level in terms of patient interaction and patient questions, so to redistribute that workload off the provider and to ease the burden there.
Great. Thank you so much, Ruth. And I'm sure there are many other ideas that different systems have had. And Amy's going to actually talk a little bit about some more tools, and I'd like to pass it over to her now. Go ahead, Dr. Tang.
I do want to inform the attendees that, Stanford Asian Liver Center has been a leader in Hep B care since the early 2000s, and they do have a really great resource called their online treatment decision tool. And they have this set up such that they're using the AASLD treatment eligibility recommendations as well as the WHO's, which was from 2015. So I'm sure that they will update this with the most recent recommendations that had just come out. But what you do is you just enter in the patient's status, their Hep B viral load, and their ALT, and then and if fibrosis staging, if you have that, and it will give you a recommendation for whether the patient should be offered treatment or should just get routine monitoring. And they do get pretty specific. They talk about what counseling you should provide around alcohol and making sure they're vaccinated for hepatitis A. So this is a good option if you want something where you can enter in specific results of your patient and then to feed back out a recommendation. I also just want to mention that we have several Project Echo sites in the U.S. and outside of the U.S. as well. There is an East Coast Echo that's run by Hepatitis B Foundation in Philadelphia, and that occurs once a month on, I believe, like a 12 to 1 p.m. time slot. There's also one that Dr. Richard Andrews involved in out of Houston, and that is also monthly. We did have one on the West Coast through San Francisco Hep B Free that was active for 2 years. It's currently on hold, and I think UCSF may pick it up to do a Hep B and C combined echo in the future. Hawaii had one at some point. So these are all actually posted on the Hep B Foundation website, so you can see what are the active echoes at any given time. But I encourage you to join even if you're not on that coast. If the time works for you, please do participate and present your cases. And this is actually exactly how myself and Dr. Wang and Dr. Andrews all learned about hepatitis B and became more confident practitioners is through the ECHO series. So I also want to emphasize that hepatitis B care programs often involve more than just the provider, but also our pharmacists, colleagues, and nurses, care managers, and peer navigators. So of course, as clinicians, we're the ones who are often doing the actual Hep B management and prescribing of treatment. The pharmacists, at least at our institution, are also involved in administering the Hep B vaccine and, of course, helping patients acquire antiviral, whether that involves a patient assistance program application or prior authorization, things like that. Our nurses are also giving vaccines in the clinic, but they can be involved in patient education. Our medical assistants in our clinic are actually doing transient elastography scans on patients. We offer it in clinic, and they were the ones who are trained as operators, and they are fantastic operators after doing several scans. We also, in our clinic, have community health workers. And so I think there's a lot of different names, care navigators, case managers. These are all, someone who is really dedicated to looking at a population level management of patients, doing outreach for those who are more lost to follow up or haven't been engaged in services for a while. I think as clinicians, we often focus on patients who come to visits who are in front of us, but there's also definitely a role for people to outreach to patients who aren't coming into clinic and who are overdue for that ultrasound or that viral load and maybe harder to reach and less engaged. And that's a very important role as well.
I'd love to hear from you guys how it works in practice is, how do we do shared decision-making or joint decision-making with patients when it comes to something like Hep B? I mean, I find in my own practice, I can have two patients who have the exact same lab tests, and they have two very different responses. One wants to get treated right away. The other one wants to wait. And I want to hear what your discussions look like with patients when it comes to treatment initiation. So Amy, if you want to start, and then Rich, maybe.
Sure. Yeah. So I don't have a specific hepatitis B clinic, but I do run the FibroScan or the transient elastography staging clinic. And I do see a lot of patients who are interested in treatment, but their provider kind of never really presented an option to them. And there's a very memorable example recently of a new father who was worried about transmitting to his newborn. And his spouse did not have Hep B, so this newborn did not get HBV, but they've got birth dose. But he was just so worried, can I hold the baby? Can I hug and kiss the baby? And while I was able to, of course, try to offer reassurance that, these are the modes of transmissions and these are not, I could totally empathize for why he would be concerned. The patient hadn't been fully vaccinated. There was no check that they had, immunity from their vaccine. And so this patient was a little bit borderline for treatment, didn't quite meet criteria. But we discussed, and I think in order for him to really feel fully confident that he could really help care for his newborn without the concern of transmitting to his infant, we decided that for him to go on treatment, at least for a year until the baby was confirmed in the end from vaccination. And so I think that every patient's situation is different, and they have a lot of concerns, not just for themselves, but their family members and people who may be more susceptible. And I think it's important to have those discussions and address for each individual patient.
Yeah, I think that's a good point. And I think what I often do for patients who I feel like should be, they do fall under the indications but aren't quite ready is to just say, well, your choice is start therapy or, we can continue to follow, right? But you need to be really good at coming back for tests so we can see how your lab tests progress, your viral load and your ALT. But it's important, like you're saying, to kind of pull out what their priorities are, right? What their concerns are, if they're concerned about liver cancer, transmissibility, or if their concern is really about, I don't want to be on a medication, right? And to work with them on that. Rich, do you have anything you want to add on to that?
Yes, thank you for bringing up this topic that shared decision-making is important. And I mean, a lot of patients, for example, I don't know the exact number, but a fair number of patients with this chronic viral illness have fatigue. And it may or may not be related to their chronic hepatitis B, but sometimes you don't know until the viral load comes down and the patient says, you know what, I have less fatigue. They may also have less anxiety because there's not only stigma against folks with chronic hepatitis B, there's often self-stigma, and they often feel better. And again, these are the kind of things, clinicians, we're not going to tell clinicians exactly which treatment criteria they have to use, but once you've settled on something, that could include, I think it's never out of order for a clinician to have the discussion with the patient, including letting them know that treatment is available. Patients won't always tell us what their risk factors are. Maybe they're periodically injecting a drug and they're not necessarily going to tell you about it, and then that places other people in the community at risk. But patients often just like knowing that their viral load is undetectable. That's often reassuring to them and also reduces the risk to folks in the household or future sexual partners. Again, patients aren't going to tell us everything. So I think it's never out of order for a clinician to have the discussion with the patient about the different, including, by the way, if I had a patient, a Nigerian patient or a Vietnamese patient or Chinese, I would also bring up, the fact that their community was significantly affected by hepatitis B and that they, in a sense, they may not want to come out and tell everybody they have Hep B and that they're on treatment. But, sometimes they could get excited about the idea that they can be part of the community level solution and having an impact on their community.
Great. These are really important points. And I think looking at patient outcomes, patient reported outcomes is something that we're hoping that is get done more, because it's not just about the liver enzymes. There's so much more that hepatitis B affects in a person's life. So we have to consider the multiple dimensions and where treatment actually could help in some of those areas that we haven't really identified. And as we know, early treatment can help prevent cirrhosis, liver cancer, and other end-stage outcomes. We're really excited about this movement, really, for task shifting, decentralizing, and getting primary care providers to really help with getting us to hepatitis elimination. We're going to be a key part of us reaching the WHO 2030 goals of eliminating hepatitis B and, being able to provide the next generation with a hepatitis B free future. And so glad to have partners like Dr. Tang and Dr. Andrews and Ruth here.
I'd like to thank our faculty for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and to view the full program on our website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. See you soon on the next episode.